The following podcast is part of a certified educational activity titled Illuminating the Path with Immunotherapy for Metastatic, Locally Advanced, and Early Stage Non-Small Cell Lung Cancer, a guide to patient assessment, treatment selection, and multidisciplinary collaboration across the disease continuum. Access the entire activity and complete the post-test at peerview.com/ZUT860. Downloadable slides and practice aids are also available.
Welcome. Today we'll be discussing Illuminating the Path with Immunotherapy for Metastatic, Locally Advanced, and Early Stage Non-Small Cell Lung Cancer, Guide to Patient Assessment, Treatment Selection, and Multidisciplinary Collaboration. This is an event by PeerView Live in collaboration with LUNGevity. We have wonderful faculty today. I'm Sandeep Patel, a professor in medical oncology at the University of California, San Diego. I'm joined by Dr. Tina Cascone, associate professor in Department of Thoracic, Head and Neck Medical Oncology at the University of Texas MD Anderson Cancer Center. And finally, Dr. Jonathan Spicer, an associate professor in the Division of Thoracic Surgery, director of the McGill Thoracic Oncology Network, McGill University. And I think I can say we have no two better experts in localized advanced immunotherapy than we have today. And what are our goals for today? Really to enhance our understanding of the latest data on immunotherapies in stage 4, stage 3 unresectable, and stage 1 to 3 resectable non-small cell lung cancer. We want to augment your skills in integrating immunotherapies into individualized treatment plans for patients with non-small cell lung cancer throughout the disease continuum. And we want to implement best practices for multidisciplinary collaboration to make the best of immunotherapy advances and improve patient outcomes in non-small cell lung cancer. Also want to thank LUNGevity as our partner. They have many patient care resources related to survivorship and support services for patients and their care partners, which is important through all aspects of lung cancer care. There are multiple immunotherapy resources as well, available in multiple languages, as well as cards you can carry, which will help ensure folks are informed about the therapies that patients are on if they're admitted to a hospital that may not be their primary site of care. And so I want to start by discussing decoding decision-making in metastatic non-small cell lung cancer, navigating the multitude of immunotherapy options. This talk is structured by starting in the stage 4 setting and we'll work our way to earlier stage disease. We have multiple approvals for frontline immunotherapy in advanced non-small cell lung cancer. And we see here on top above the timeline, chemotherapy combinations with immunotherapy, started with Keynote 189 through 407 for squamous disease, IMpower 150, which integrated atezolizumab, and bevacizumab, an anti-VEGF targeting agent, IMpower 130 looking at squamous, Checkmate 9LA looking at anti-CTLA-4 blockade after 2 cycles of limited chemotherapy with nivolumab, the Empower Lung 3 study looking at cemiplimab plus platinum chemotherapy, and Poseidon looking at durvalumab, tremelimumab, and chemotherapy. For immunotherapy monotherapy, we have a multitude of choices, but these are biomarkers selected for pembrolizumab, PD-L1 greater than 50% by TPS score, the Keynote 24 study, the Keynote 42 study looking at a TPS cutoff of 1%, IMpower 110, which looks at atezolizumab for PD-L1 tumor proportion score, tumor score greater than 50%, or immune cell scoring 10%. Nivo-Ipi, PD-L1 greater than 1%, and cemiplimab, PD-L1 greater than 50%. I think one thing that's very important about all these regimens is these include patients without EGFR and ALK mutations. This is important because you can have a PD-L1 score with concurrent EGFR ALK aberrations, so we should not act based on the PDL score by itself. We must look at the totality of the genomic data, including EGFR and ALK. And so let's start with a case to get us going. This is a 67-year-old gentleman who quit smoking 30 years ago and is found to have a 3.4 centimeter right middle lobe lung mass on a coronary calcium scan. The PET-CT revealed a 3.4 centimeter right middle lobe mass with right hilar and subcarinal adenopathy and L1 12th rib and left scapular metastasis. The MRI of the brain was negative for CNS metastasis. This patient has hypertension, gout, hyperlipidemia as comorbidities, but is good performance status, ECOG 0 diagnosis, with some mild left upper back pain, likely related to metastatic disease. On pathology, an EBIS shows metastatic poorly differentiated carcinoma with both glandular and squamous features, with patchy TTF1, negative for napsin A and P40, KRAS G13D mutation with a PD-L1 TPS score of 60%. So how do you think about this patient? KRAS G13D, PD-L1 60%, stage 4 disease. Tina, how do you go about thinking about this discussion with the patient about treatment?
For sure. Thank you, Sandeep. I think this is a typical scenario that we encounter in clinic quite often. I have to say this is a gentleman with an excellent performance status, CCOG PS 0, which is definitely an important factor together with the tumor burden. So the amount of the disease here, we appear to have to deal with an oligometastatic disease. So we have some sites of bone involvement based on which the patient is now symptomatic. The TPS, tumor proportion score for the PD-L1, is an important factor here. If together with these other elements, I have to make a decision in this case, I think that is very appropriate to go ahead with ICI monotherapy. We are in the context of a high PD-L1, so 50% or higher. We've learned that in this setting, really the outcomes are quite similar with the presence of chemotherapy plus the addition of ICI or ICI alone. So in this specific context, I would just go ahead with a single agent pembrolizumab, atezolizumab. You educated really wonderfully on all the options and the approvals that we have in this setting. I want to mention that this is an important element, the tumor molecular profiling. We will learn as we go later on the KRAS G12C, not to be confused here. So I really appreciated how you really delineated this molecular profiling. We cannot stress this enough. Please make sure to test your patients in the metastatic setting, and we'll see, going through the resectable and as well as unresectable. So this is definitely a typical case where I would start off with immunotherapy alone, and if the tumor burden had to be higher, more robust, more symptomatic disease, that's definitely when the chemotherapy will come in play.
No, I think it's a great point.
I'm just curious with your thoughts on the study that came out today on oligometastatic consolidation. Does your choice to go with concurrent chemoimmunotherapy, is it impacted by your plan to go to local consolidation, or how do you structure that?
Yeah, that's a very important question, and I'm glad you mentioned that. Quite an impressive, surprisingly, to see this data. I have to say, just for the sake of the discussion, the NRG LU002 really underwent several amendments with several changes, right, as to tailor what we have available for our patients to the population on trial. And so really from an oligometastatic definition, you saw that wonderful discussion, really up to 25 sites of the disease, if I recall correctly, as well as the ability to radiate some sites even before enrollment, brain disease, and then allowing immunotherapy. So definitely the era has changed as compared to when the LCT trials started. I have to say that in our practice, we still do consider LCT perhaps more with radiation therapy versus surgery for patients who have an outstanding response.
I think that's a great point. I think for a patient who has an amazing response, maybe a single PET-avid lesion remaining, thinking about SBRT may make sense. I think in terms of supportive care, thinking about skeletal support for these patients, whether
Absolutely.
it be denosumab, zoledronic acid. I think one point that we may want to talk about is, what's your molecular testing strategy look like? How do you get the answer quickly? Because patients are nervous. They've probably been delivered the worst news of their life. They're very anxious to start treatment. This patient looks like he has some mild symptoms and can wait. What does that discussion look like in your clinic, and how does testing look like in your clinic?
Yes, so absolutely. We do not miss any patient for testing. So that's something that I cannot stress enough. And I really want to encourage everybody in the room to take that really to heart. This is an important point for our patients. In that discussion, I have to say, in my academic center, I'm fortunate enough to be able to do both a liquid molecular profiling, especially in the scenarios where I'm still waiting for the outside hospital biopsy that has to come to my center for pathological confirmation. So that has a relatively quicker turnaround, about 7 to 10 days. In the metastatic setting, especially when we have a higher tumor burden, the sensitivity goes up. So that's slightly more reassuring, right, in the amount of information that is going to be needed to tailor treatment. And then definitely usually the NGS-based panel on tissue. If I'm unable, because of paucity of tissue, I definitely try to get the minimum necessary to decide whether I have to do immunotherapy versus targeted therapy. So at least PCR-based EGFR or FISH as well for the ALK.
I think it's a great point. I think, in my clinic, I order cell-free DNA and tissue-based NGS at the same time, including RNA-seq, not to get duplicative testing, But because oftentimes the cell-free comes back in 1 week before you even cut the tissue to be sent, or it's an outside hospital, and then you can cancel the tissue if you get your answer in liquid. If you don't have your answer in liquid, you're a week ahead of where you'd have been if you waited in terms of an inverse reflex strategy. But John, how does testing look like maybe in the metastatic setting? And we'll talk about localized later.
Yeah, so it's been a few years now, but maybe just 2 since the government reimburses all forms of testing across stages, and it's really reflexive, triggered by the pathologist. So if the clinician doesn't have to make a request. For patients who have non-squamous histologies, 52 gene panel will be done reflexively, and PD-L1 will be done across all histologies reflexively as well. The only scenario where we'll sort of get a tumor board or clinician requested NGS panel is, say, a squam in a non-smoker or some sort of unusual situation, then we'll request it more specifically.
These are actually very good points. Sandeep wanted to ask you, what's your practice in presence of, squamous histology or a never smoker? I tend to really profile where I can everybody, every histology, regardless of smoking status as well.
I would agree. Many of these tumors are small biopsies. It could be adenosquamous. I found NET. I found ALK sometimes. And so smoking history, I think we mentioned a couple times. I think it's an important point. You can have a 50-pack your smoking history, and you still have a 10 to 15% chance of an EGFR mutation, especially depending on your background. And so smoking history should not guide whether one tests or not. We should be testing all these patients. And in my opinion, we should be testing squamous as well. And that's what I do in my clinic, especially with a liquid biopsy where you're not sacrificing tissue you may need for other purposes. I cannot agree more. Great. So great discussion. But I think, you heard that it's important to get the proper molecular testing. And there are multiple reasonable options in the frontline space. So let's take a little bit of a twist on the first case. So this is a 62-year-old female, current smoker, presents to the ER with 1-month history of progressive confusion. MRI of the brain is positive for a 3-centimeter front lobe metastasis. A neurosurge took her to the OR because of these symptoms urgently, and the pathology shows adenocarcinoma, KRAS G12C Charlie, with STK11 KEAP1 co-mutations detected, PD-L1 negative. The CT scan revealed large left lung lesion eroding into the left chest wall and with a right rib metastasis. She's recovered from her surgery nicely, and she has background coronary artery disease and COPD. Couple options. So KRAS G12C inhibitors, we saw some interesting data, but in terms of standard of care, these are in the second line setting, though maybe in the future thinking about patients with chemotherapy plus. ICI monotherapy, PD-L1 negative patients, the response rates may be lower. ICI with chemotherapy, which I think may be one potential standard of care. Dual ICI without chemotherapy or with chemotherapy, meaning CTLA-4 PD-1 or PD-L1 blockade. So Tina, how do you think about this case? What does the discussion look like in your clinic?
Yes, absolutely. So this patient has definitely some degree of tumor burden and a very interesting molecular profile with important co-mutations and with a PD-L1 TPS 0, less than 1% negative. So in this situation, as a standard of care in the frontline setting, platinum-based chemotherapy with ICI monotherapy would be absolutely appropriate. I want to remind us that we have, as part of standard of care, KRAS G12C inhibitors in the second-line setting, as Sandeep mentioned. Now those agents are being tested in the frontline setting, but at this moment in time, the standard platinum-based chemotherapy plus immunotherapy is the choice to go with. I want to mention that with this molecular profiling with these commutations, I would be tempted if there is a very optimal performance status to work with, and of course after discussion with the patient and explaining very well what a dual immune checkpoint blockade entails, I would consider the checkmate non-LA paradigm with the dual immune checkpoint inhibition, PD-1, CTLA-4, and platinum-based chemotherapy, or the Poseidon paradigm with the durvalumab, PD-L1, tremelimumab, CTLA-4, because we have seen in retrospective analysis from these trials a higher degree of benefit from the combination in PD-L1 negative patients which have an enrichment of commutation with the KEAP1 and STK11, which again, across several cohorts in retrospective analysis have shown to be poor predictors of response to immunotherapy or predictors of lack of response. So that would be really my choice here, either, again, a checkmate non-LA with nivolumab, ipilimumab, and chemotherapy, or Poseidon with the dual immune checkpoint inhibition.
Maybe I'm jumping the gun, and maybe it's not a fair question, but in the NeoStar Arm D, did you have any co-mutants for STK11 or KEAP1, and could you comment on response?
Yes, I'm glad you're asking this, John. So as you know, we did some initial post-hoc analysis with the clinically available, so standard of care molecular profiling, NGS, so ctDNA-based from our practice. And we did see some presence of KRAS mutations, as you know, is in the supplementary data. And we definitely see that there is a much lower residual viable tumor for patients with KRAS mutations in presence of CTLA-4. But the number of patients with commutations was very small. Actually, we had no KEAP, but in presence of STK11, we are talking about an N of less than 5, and so I want to be very cautious and mindful in making any conclusions.
That's fair.
That's a great point. And you actually wonder if there's some stage effects that you may have selected against KEAP by going in a surgical study, where oftentimes you have a more aggressive biology.
Absolutely.
Yeah.
Absolutely.
No, that's a great point. And so we had a nice discussion around probably the best option for this patient is chemoimmunotherapy. Whether that be with PD-1 checkpoint blockade by itself, or adding a CTLA-4 inhibitor in the context of checkmate 9LA or Poseidon. I think it makes sense. In my own clinic, I think about adding a CTLA-4 in patients with brain metastasis, STK11 KEAP1 co-mutation, PD-L1 negative, squamous histology, typically are the 4 settings I think about it. But it's a problem. We don't have a positive selection biomarker for CTLA-4. And so we're making inferences based on clinical characteristics, which is somewhat less satisfying, but at least across multiple data sets, we've seen some of these themes.
I think this is really an important point and an urgent need, really understanding at baseline what are predictors, right, of responders to the addition or the need for CTLA-4. I think that we are really aligning towards, the prospective testing of this question into randomized phase 3 trials. I think we have trials upcoming that will definitely answer this question in the PD-L1 negative population, but trying to understand what are the factors, patient-based or tumor-based, that can tell us who are the patients who will benefit the most from the addition of a CTLA-4 inhibition is paramount.
Absolutely. I think it's a great point. And we actually have a similar problem with ADCs, right? Our biomarkers, especially for several ADC targets, it doesn't recapitulate the biology. And so we struggle with the CTLA-4, we're struggling with ADCs. I think we had a nice discussion around how the STK11 KEAP1 co-mutation kind of compounds an adverse, both predictive and prognostic effect. There is some data that CTLA-4 blockade may be more efficacious there. Do molecular factors play a role in your consideration around oligometastatic resection? I know these probably are somewhat rare and they're often with your colleagues, but Jonathan, just out of curiosity, does that play a role, the molecular selection?
I think it enters into consideration for the whole team, right? When you have STK11 or KEAP1 in play, your expectations on response are much lower. These patients frequently progress on that treatment, and so you might be a little bit less optimistic about it, but you'd still re-image. And I think that there's actually great data that's come out of the MD Anderson group about the site of metastasis. We know classically brain and adrenal tend to have better prognosis, bone metastases less good. I think it'll be a challenge probably moving forward with the results from the LU002 trial to continue to consider oligoconsolidation, but there's clearly some subsets in whom it's beneficial, and it's usually those who have good response and to targeted therapy and things like that. But simple answers, it enters into our consideration, but we usually have the same approach: best systemic, rescan, and then consider based on fitness and amenability to local therapy.
Yeah, no, I have to say, yesterday as I was listening and being educated from the results of the LU002, the NRG, I really felt that we don't really know at this time, and we just have to be humble enough to understand that we have to do more research, and probably it's not a failed paradigm. I think that we still have some buckets of patients that will benefit from that local consolidation, whether it's surgery or radiation-based therapy. We just don't know who they are yet. So I'm really looking forward to see subgroup analysis from that cohort. It will definitely inform the next generation of trials.
Absolutely. And I think the other thing that's been really clear from this ASCO meeting even so far is finding that first mutation is necessary but not sufficient. And we're actually starting to sound a lot like the malignant heme doctors in terms of favorable cytogenetic risk. Right now, we're looking at compound mutations, STK11/KEAP1. And so our tumor boards are starting to sound a little more like our malignant heme colleagues because we're trying to profile patients. And a lot in the metastatic setting can be done in liquid biopsy, which is nice. Let's talk about subcutaneous administration, which has actually been a hot topic not only for bispecifics, but also for immunotherapy. So traditionally, these immunologics are administered IV. And I think concurrently with chemotherapy, it makes sense. You have a port, you have IV access, and you get all three. But when patients switch over to maintenance therapy, or maybe they're PD-L1 high and they're getting monotherapy, do you have to have access at all? Do you need a port? Do you need to work on IV? And so there are multiple subcutaneous formulations actually approved in some jurisdictions. Atezolizumab for non-small cell lung cancer in the EU across all indications, nivolumab for RCC, sasanlimab, and relatlimab, nivolumab in metastatic melanoma. And so, especially in your clinic, Tina, I'd love to hear, patients travel far and wide. How does this affect your thinking about these agents? Would you use them? Did they are utilized? Do you need more evidence? What are your thoughts?
Yeah, I think this is an important step forward to really tailor all the great treatment options that we have now to our patients and their needs, and their entire support system. It's not just our patients, but the caregivers who have to take off work to take them to our location for treatment. These are not trivial considerations. I think that's something that as we face every day in clinic, these are actually important factors that really bog down the quality of life and the functionality of our patients. So I definitely am pro these agents. I was very enthusiastic to see the data of the amivantamab yesterday from Dr. Leal from the Paloma tree. Definitely a lot of more work, but definitely encouraging data. And so here in this setting, definitely it's important to see as the data unravel with longer follow-up. But I think that definitely alleviating the need of ports with all the safety issues and the complications. We all have gone through infection of a port. We all know what that means for our patients and for the entire hospitalization and so forth. I think that reducing the leisure time loss, I think that's very important. I think optimizing the occupancy, I think it definitely can give slots to patients who might not have the opportunity to, that cannot have a subcutaneous formulation, need to have an IV administration. So definitely a tremendous impact, not only on patient care, but on the overall patient quality of life and supporting system. So absolutely, pro.
Yeah. And this is a problem that was created by the success of these agents, and the need to continue to administer these generally for 2 years in the context of these clinical trials. Secondarily, we talked about the medical toxicity, kind of the patient discomfort around IVs or ports. But there's this concept, and you've heard it at this meeting, called time toxicity, and the amount of time the patient spends in clinic. Especially as these agents are highly effective, they get their lives back, they want to spend less time in clinic. That's perceived at that time, just like a watched pot never boils. They're waiting in infusion. And so I think this really can improve the quality of life, and I have a lot of confidence in switching to sub-Q once they're available in the appropriate settings, and we see a couple agents and settings that they are. Also at ASCO, there was some updates. We had 5-year outcomes for multiple studies, but including CheckMate 9LA. This is 2 cycles of chemotherapy in combination with nivolumab given every 3 weeks and ipilimumab given every 6 weeks. So the way it's utilized in non-small cell lung cancer, a little different than what we see in melanoma and renal cell carcinoma. It's 1 milligram per kilogram every 6 weeks. And here the 5-year survival is really just recapitulated the data we've seen with multiple time points, typically a 2-year regimen, and a patient's doing quite well with some interesting cohorts in PD-L1 negative, some interesting data on STK11/KEAP1 and brain metastasis. Tina, any other insights from this more recent data, or has this influenced how you think about different patient populations?
No, I think it continues to reinforce really the consideration of specific subgroups that really deserve the dual immune checkpoint inhibition. I'm really enthusiastic. I was enthusiastic with the 4 years data recently published, very enthusiastic to see the 5-year duration of response, in the PD-L1 negative population, 25% versus no response. So I think that's really encouraging, and then it tells us even more. It reinforces the concept of more work and biomarker-driven and translational research to be done in this patient subgroup. I don't think all patients deserve the CTLA-4 blockade, but definitely there are some patients from the NeoStar trial BND that, as a matter of fact, after 5 years, are still without evidence of disease. So that's absolutely important to understand who are those patients moving forward. So I'll take over from Dr. Patel, and now we're charting the course of immunotherapy in the locally advanced non-small cell lung cancer and how to optimize multimodal strategies. So really, this is the trial that has revolutionized how we treat patients with locally advanced stage 3 unresectable non-small cell lung cancer. This is the Pacific trial. We've seen many publications from this trial from 2017 till last year, and I'm sure we will see more in terms of as the follow-up extends and as we do more subgroup analysis. This was a phase 3 randomized double-blind placebo-control, of course, global multi-center trial, where stage 3, again, with locally advanced unresectable non-small cell lung cancer, who had not progressed following definitive platinum-based concurrent chemoradiation therapy with at least 2 cycles, with a performance status of 0 or 1, with an estimated life expectancy of at least 12 weeks, were randomized, usually in 1 to 42 days post the definitive paradigm, to receive consolidation therapy with durvalumab, a PD-L1 inhibitor, every 2 weeks versus placebo for 1 year of length of time, so 12 months. Here the endpoints were co-primary PFS by blinded independent central review based on the RECIST criteria as well as OS, and then a number of key secondary endpoints, including, of course, the objective response rate, the duration of response, and time to distant metastasis. We have seen updated overall survival and PFS data at approximately 5 years after randomization, after the first patient was randomized. And so here we have the JCO data from Dr. Spiegel a couple of years ago now, where you can see on the left overall survival data. So at 5 years, you can see in the durvalumab consolidation arm, almost 43% of patients alive as compared to 33%. I cannot see anything, so I hope that my memory serves me well on this very small number. And then in terms of PFS at 5 years, I believe approximately 33% versus 17% patients free from progression in 5 years. So quite impressive data if we think about really the poor prognosis that we have for our patients. Now we're even thinking about these patients in the surgical setting. We'll talk about that in a little bit. But definitely, how do we take this data into practice? We have to consider some subgroup analysis. This is very important. We do not select patients based on the PD-L1 for the consolidation durvalumab paradigm, but we should definitely consider not to include patients with EGFR or ALK aberrations. You can see here definitely the differences for benefit in patients with positive EGFR mutation, almost lack of benefit with a hazard ratio of 0.85. With durvalumab in the consolidation setting as compared to negative wild-type EGFR 0.66. And as far as the PD-L1, you can see here the dichotomization 25% or higher versus less than 25%, slightly atypical compared to what we're used to see in practice in terms of 1%. Less than 1%, 1 to 49, and 50% or higher. But you can see here that definitely in the patients with positive PD-L1, 25% or higher, and hazard ratio of 0.52, and perhaps really less benefit, close to none, with 0.9 for patients with less than 25%. We don't know what's the distribution in that less than 25%, how many are really zero, or there is more of a very low expression. So I want to stop here for 1 second and ask Sandeep, perhaps again in this setting, do you test this patient and how do you use this post-hoc analysis for practice management?
Yeah, it's a great question. In the United States, the label for Pacific is independent of PD-L1 status. And there's a lot of missingness in the data. In fact, as you show here, unknown represented probably the second biggest group, right? And so this wasn't a study that was designed to look at that cohort, and so I typically don't test for PD-L1. I will be testing for EGFR in this patient population soon on tissue, but I think PD-L1, if I had to pick one test to do, I'm picking EGFR.
And you probably should do that specifically in what we're seeing tomorrow coming on, and we'll talk about what is going to be presented in plenary session. Perhaps provocative question for Jonathan. Sure. In the stage 3 setting. How are we approaching this disease with or without surgery now?
Well, it's getting quite complicated, and even more so, I think, now with the LAURA data that we're going to see tomorrow. I think, I understand that the label, it's true in Canada as it is here, that it's PD-L1 agnostic, but in Europe, they chose to exclude PD-L1 negatives. The hazard ratios don't look so
impressive.
Good. So I think our oncologists tend to have more of a discussion with these patients about the utility of going on to that extra year of treatment. That debate, I think, is much less present in the perioperative or neoadjuvant space, where you're administering the standard of care for metastatic with concurrent chemo, PD-1 or L1. And at least the meta-analysis data that we'll get to later is favorable in the negative patients. So, there's a lot to discuss here, but I think that when a patient is operable for PD-L1 negative, I would probably err on the side of perioperative strategy.
Yeah, that's absolutely right. And I think to this point, I really wanted to put this data here because I think it's quite important. This is a publication from the Pacific trial. It's a post-hoc analysis from a couple of years ago that really looked at the benefit in terms of PFS and OS from the consolidation durvalumab in patients with stage 3A and 2 on the left as compared to patients without stage 3A and 2. So as you can imagine here, we're talking about patients classified based on the AJCC 7th edition. Now we're thinking on the 8th edition. Actually, we've been thinking on the 8th edition since 2016, and we're probably soon going to start to think about 9th edition. You can see from these curves how definitely there is an interesting magnitude of benefit in patients with 3A and 2, where we have a poorer prognosis based on the more extensive nodal involvement. And you can see here at 1 year PFS, approximately 59-60% for the durvalumab arm as compared to 32% or so for the control arm. Again, a much worse prognosis for patients in the blue curve with more extensive nodal involvement. And I think as a ratio here is at 0.46. And the overall survival, really recapitulating this data, you can see an as a ratio 0.56 for patients with the durvalumab with stage 3A and 2. So larger separation of the curve, again, exploratory analysis, but definitely something to keep in mind for these patients with larger tumor and more nodal involvement. Sandeep, how do you look at this data for the patients with stage 3 and 2 disease?
I think this is the most complex area. Probably we discuss at tumor boards, and we spend the most time here. But I think the promise of immunotherapy in this setting probably has the greatest improvement and greatest ROI. And so that's why these discussions are so intense. I think whether these patients get immunotherapy or not, the answer is they will get immunotherapy. The question is in what form. Are they going to get neoadjuvant, perioperative, and that's really a local decision on surgical resection, versus potentially multi-station disease or a patient who's just not fit for surgery, who's getting concurrent chemorads and durvalumab. And so I think the immunotherapy question set, so I kind of quietly sit back at tumor board and let my surgeons and radiation oncologists decide the optimal surgical versus radiation approach.
I absolutely appreciate the ROI, the return on investment in really tailoring that treatment with our patients now that we have these options. I think it's such a critical process that we have to take so seriously, specifically for this patient population that we will see and we'll learn, I think, with presentations from tomorrow and Monday at this meeting, how are the clinical outcomes of patients with stage 3 and 2 and non-into disease with a perioperative approach. So please don't miss these presentations because it's going to be, again, a very critical topic to discuss. Now, as Sandeep mentioned, how the patients are going to get immunotherapy at some point. How do we implement that strategy, right, in the cancer therapeutic journey for our patients? There are several trials that are testing immunotherapy in different strategies, sequential or concurrent for patients with unresectable disease. The Pacific 2 results have been presented at the European Lung Cancer Conference this year. Negative results from adding immunotherapy in the concurrent chemoradiation phase. We have learned from a press release that the Checkmate 73L, also negative data. We are going to learn about this data in the upcoming meeting. But again, probably some form of immunotherapy might not necessarily be in the concurrent phase. But to Jonathan, perhaps, again, another provocative question, We have seen in the neoadjuvant phase for patients with resectable disease what the impact of stereotactic radiation therapy with immunotherapy has been.
Right. So, I mean, I think everyone was disappointed to see the results of Pacific-2, where there really wasn't much of an effect. But the data from Dr. Al-Torki's randomized trial comparing durvalumab alone to durvalumab with SBRT, which was sparing the nodal basin, was really focused on the primary tumor, is compelling in terms of the potential for combination. You went from I don't know the exact numbers, but 10 to 15% PCR rate all the way up to 50% for what it was a relatively light regimen in terms of toxicity. So I think one thing that's conspicuously missing from this list of trials is sort of neoadjuvant chemo-IO followed by CRT trials, and I think some of those are ongoing. It also kind of speaks to how we're going to handle the population of patients assigned to a neoadjuvant strategy who don't make it to the OR. What is the right way to approach these patients if the progression is only local regional? So a huge amount to develop in this space. But to me, if you're able to induce a PCR rate with chemo-IO in 25 to 35% of patients, that's a good starting point to come in and do some RT consolidation, at least from a, thought experiment perspective. It's probably something that could be.
Sandeep, what do you think?
I would agree. I think one more, maybe even more provocative question is our colleagues who treat rectal cancer,
Right.
Who give immunotherapy up front, are now starting to ask the question, if you have a path CR, do you need some of these radiation approaches or things like that? And so I think one of the things we learned a lot about immunotherapy from the melanoma docs who trailblazed. And I'm curious how much we can learn from each other in terms of how to best integrate these approaches, because this is curative intent surgery, right? And immunotherapy really augments the ability to cure either by radiation or surgery as local approaches. Maybe one step back, because this is a very common problem that happens in my clinic. I'll get a patient who maybe has a PET CT where there's mediastinal involvement, but they came from an outside hospital, the primary biopsied. How do you handle that clinic? How do you handle it in your clinic? Are you sending them to your interventional pulmonary docs? Are you going to take them to surgery and do the bronchoscopy and then do the surgery based on what you find? How do you handle that particular scenario in clinic?
So you mean a patient that's sort of been incompletely staged?
Exactly, yeah.
Well, I think it's quite vital to get proper staging. Shankar Siva's study, I think it was Saffron, showed the importance in the unresectable setting of getting appropriate mediastinal staging. It's certainly true in the surgical domain. So you have to take the time. I think people have this sense of urgency when you're in the curative space, but taking that extra time is well worth it in the long run to assign the patient to proper treatment. And I don't really think it's a couple of weeks or even 3 weeks or even 4 weeks that's really going to make the difference. You have to take the time it takes to get the right information.
So how do you handle, because pathologic staging is the stage in this setting?
Absolutely. I think it's paramount to perform a proper invasive mediastinal staging, regardless of the initial PET, contrast, and CT. All our patients should have an interventional pulmonology consult for EBUS, or if we get an EBUS negative sometime in presence of a PET positive, we ask our surgeons to perform a mediastinoscopy unless there are risks, bleeding or location of a lymph node that is not easily accessible. Then in that case, the PET staging will still be maintained. But I think that it's absolutely paramount to have that staging properly done. We see sometimes N2 skipping, right? And that's just so terrible when there is nothing in the N1 and there is nothing on the EBUS, and then when they go to surgery and our patients have N2 disease all over. And that's when you have to tell your patient, let's look at radiation, let's look at chemotherapy, and so forth. So
it was the seismic study but it really demonstrated the importance of proper staging. Even to plan your RT fields, right? I'm not a radiation oncologist, but you need to know what's involved to be able to not do too extensive fields, not to treat benign positive PETs, positive nodes on PET. It is extremely informative.
And many times we see this outside hospital, outside of our center, invasive mediastinal staging with simply one lymph nodal station that is positive PET analyzed, and there is not an N3 evaluation or a multi-N2, and that's something that I've learned is absolutely important to do to understand whether a patient can be potentially resectable versus disposition to the Pacific paradigm. Before we move forward, I just want to mention the LAURA trial that you see at the bottom of this list. I believe that this is probably the most important trial that the community is waiting to hear results from tomorrow in plenary session for the role of consolidation osimertinib in patients with EGFR mutant locally advanced unresectable non-small cell lung cancer after concurrent chemoradiation therapy. In terms of additional updates from this ASCO, you have here the results, the updated results from Dr. Agrawal from the COAST study. This was a phase 2 study of durvalumab plus novel agent immunomodulatory agents, the oleclumab, which is a CD73 inhibitor, as well as monalizumab and NKG2A inhibitor for patients with stage 3 unresectable non-small cell lung cancer. And we'll have the Pacific 9, that is a large almost 900 patients trial testing in the phase 3 setting the addition of oleclumab or monalizumab to these patients. So let's stay tuned to see. We have seen from these updated data definitely an improvement in the median PFS and improvement in the median OFS with the combinations as compared to durvalumab, but a lot to be learned about these novel agents. So let's go to another case. We have a 65-year-old healthy woman with a left upper lobe adenocarcinoma. CT screening showed a 6.1 centimeter left hilar mass with what we're told the tumor board a vascular and pericardial invasion based on radiological examination. This subject underwent a PET scan with an SUV of 17 in masses and 13 in the lymph nodes. Had a left upper lobe CT-guided FNA, fine needle aspiration, which showed a poorly differentiated adenocarcinoma, underwent invasive mediastinal staging with EBUS, bronchoscopy, 4L and 7 stations, nodal stations positive for adenocarcinoma, and the right paratracheal 4R negative. Biomarker testing was done, PD-L1 negative, KRAS G12C, ATM mutation, tumor mutation burden stable, 9.5 mutation per megabase, final clinical stage T4 and 2M0. So a really interesting case for our tumor burden discussion. So these are the scans. You can see here the view at the PET scan as well as the contrast enhanced CT. So I'm going to pause for a second and ask Jonathan, as the surgeon at our multidisciplinary tumor board, comments here.
Yeah, so this is a great case for discussion because it really is on that borderline designation. You know, here we go. Look at this. So, like, I think people read these scans a little bit differently, but for me, this is the primary tumor. This is what we're seeing up here. Some radiologists might call this mediastinal invasion. Some might say it's not. And these are comments that come up in the tumor board and that need to be dissected by a team of doctors. For me, this is probably hilar N1 disease. Some people might call it a second tumor, and you don't really know until it's out and the pathologist can look at it. And then here you have a 4L lymph node, which was proven. We don't see the 7 disease, but you believe that it's positive from the EBUS. And you can see this lymph node is quite different in its anatomic description as compared to this 4R, which is discrete. There's a little bit of fat inside. You can see the hilum, and that's an easy to resect lymph node. This one's more infiltrative. It's accosted to the bronchus. It's in the region of the recurrent laryngeal nerve. So there's a lot of considerations if you're going to go try and extirpate this in terms of morbidity and causing injuries there. So yes, it's in the domain of what could be resectable. But if you're going to resect this, it's going to be a very challenging case, and the risk of pneumonectomy, I think, is reasonably high. So a lot to talk about.
I tend to agree. This is, in this moment in time, our standard of care for patients with large tumor with potential vascular and pericardial invasion and multi-station N2. But again, what we learn from this ASCO meeting perhaps can bring more food for thought, I would say, into the tumor burden.
And one interesting point, if we're in Europe, this patient's PD-L1 negative.
It's
so they
not
actually,
even an option.
Yeah, so they wouldn't actually have Pacific as an option. And one thing we're aware of, and I know we're going to talk more about later, but just wanted to whet folks' appetite for this topic, is in that case, having the intact tumor and getting neoadjuvant or perioperative chemo-IO may be the only option at a definitive local procedure for that patient. And thinking about multi-station versus single station may or may not be as relevant in the era of IO given preoperatively, because actually having that tumor in situ, having it there at the time in which you give IO, has kind of a bit of a pseudo-vaccination-like effect. You get tertiary lymphoid structures, you get lymph nodes that may or may not try to fool us. And so this case may be complex depending on where you are as well.
Mm-hmm. Yeah, I cannot agree more. I think that, again, to your point, the European regulatory authorities didn't approve also the neoadjuvant nivo chemotherapy regimen in the PD-L1 negative, so that's only available in the PD-L1 positive disease, as instead here our FDA granted us the approval in all comers. So all perioperative here is approved for all comers, so that's something really to consider, especially as we think about the potential power of that immunotherapy with chemotherapy in the perioperative space to minimize the negative prognostic impact of nodal involvement.
Yeah, so one maybe question for both of you is, so one scenario we actually see too frequently. We're all excited about the high PCR rates, but the truth is it's only about a quarter, maybe a third, and there's a lot of patients who have non-response after initial treatment. So we have a fair number of patients who will undergo neoadjuvant treatment, will have their resection and maybe have persistent N2 or have, still a significant burden of disease. Here in the US, you have the option for adjuvant IO. We don't yet have that in Canada, but how do you handle these patients in terms of managing progression?
Yeah, I think that we're still learning, right, the patterns of failure in the context of neoadjuvant and perioperative therapy. I think you, Jonathan, last year at ASCO gave us some very nice data from the Checkmate 816, where the neoadjuvant nivo plus chemo, it's very impactful in reducing, right, the rate of distant metastatic disease. And that was quite impressive. And so that tells us that perhaps even the patterns of failure are really changing and evolving as we implement these agents into the earlier stage, as well as in the locally advanced unresectable, because we all have to deal with the question of how do we treat our patients that we're treated with Pacific paradigm after 1 year of immunotherapy and with progression? Do we consider the window of time free from progression to re-challenge with immunotherapy? Do we re-irradiate? What is the pattern of progression? Sandeep, what do you think?
Absolutely. And so for me, we have multiple reasonable options, luckily. But kind of where I've settled, because you have to make a choice in clinic, is I typically use Checkmate 816 up front. And for a patient that's PAT-CR, I think they graduated, they did great. I think for a patient who has 90% residual viable tumor, right, we're in trouble, right? Because giving more IO is probably not going to move the needle. That's probably your reflex, but that's probably where intensification strategies, there's some studies with ADCs, for example, things like that, trying to switch up the playbook a bit. And then I kind of go green light, yellow light, red light when I'm talking about these patients. Green light, if PAT-CR, red light if it's 90% residual viable tumor. I think it's the yellow lights where you get like 50% tumor killing after 3 doses that you may get higher return on investment for the patient's cost of this and also the systems, to giving nivolumab on the back end, such as Checkmate 77T.
And I agree completely. And if you look at the very beautiful analysis that John, you and Patrick and Johnny Staub and the entire team with the Checkmate 816 have done, looking at the percentage of residual viable tumor in association with EFS. And it's beautiful to see that 90% of patients, if I recall correctly, are alive and event-free at 2 years if you have 0% residual viable tumor or 5%, so near PAT-CR. And when you start moving towards the 6 to 30%, that perhaps where you might continue the immunotherapy. You don't have a PCR, but you have some residual viable tumor, so it would make sense to continue that treatment. But when you go over the 31, that's where really your prognosis becomes absolutely poor.
I know our oncologists are, basically when we report at tumor board after resection, we say, 85% RVT. They're starting to look for the trials on that day. So we're not giving them extra treatment, but we're not sure what to give them because they've sort of failed first-line metastatic treatment.
those are the patients who must be intensified rationally, absolutely. So again, a lot of discussion here. This is a case that would be well dispositioned to concurrent chemoradiation therapy followed by consolidation durvalumab, but there could be consideration for neoadjuvant chemoimmunotherapy followed by surgery and perhaps additional immunotherapy, again, based on a number of factors. And I also want to remind us that now we have trials that are testing a very important question. Regardless of resectability, in patients who have unresectable disease, shall we start with a neoadjuvant chemoimmunotherapy and then decide whether we want to continue with surgery or do a concurrent chemoradiation approach?
I think, Tina, to your point, it's a very good one. Right now, resectability is determined at the time at which you meet the patient. We don't yet have strong data on what's called conversion therapy, meaning give them some chemo IO, see what the scan looks like, and then consider resectability. Those studies are ongoing, but I think it's important when we're talking about resectability, the definition, that's really the time at which you meet the patient.
So we'll move on to, again, the hottest topic of this ASCO meeting for the lung cancer community. Really, I think that we will be in the plenary session tomorrow, perhaps an hour earlier, to make sure that we have a seat. An impressive press release for patients with unresectable stage 3 locally advanced EGFR-mutant non-small cell lung cancer. Here we know from a press release from a while ago now from the phase 3 LAURA that the consolidation of osimertinib after concurrent definitive chemoradiation for these patients show a statistically significant and a highly clinically meaningful improvement in PFS for these patients. So really looking forward to see this data. The LAURA trial tested in patients, again, with stage 3A, 3B, and 3C EGFR-mutant non-small cell lung cancer, the following concurrent chemoradiation therapy, a 2-to-1 randomization of consolidation osimertinib versus placebo. Here with the opportunity to continue osimertinib at progression and to have patients on placebo to cross over to osimertinib. So I want to pause for 1 second here. An important question for Dr. Patel, for Sandeep. Here we have the osimertinib anti-progression. We have seen from the ADAURA in the resectable EGFR setting, 3 years of osimertinib. What do you do in practice, and how would you envision this continuation of osimertinib until progression?
Yeah, it's a great question. And then the other kind of complexity here is oftentimes the biopsies are very small. And so getting sufficient yield, because liquid biopsies less likely to yield a result, is going to be a challenge. But I think broadly, I'm going to test for EGFR. And I think as I think about duration of therapy, ADAURA is 3 years of therapy. And in the adjuvant setting, I'll offer the patient the opportunity for a break at 3 years. I mean, that's the way the study was designed. And I'll often get a CAT scan, and I'll get cell-free DNA. There's not yet a rule for that in the standard of care setting. Basically about a month after we take a break and try to get a scan, about 4 to 6 weeks after. And if it looks like things are coming back, then that's a patient that may need it indefinitely, which is really what we're seeing with LAURA, right, which is indefinite osimertinib. But not all patients need it. In a sense, right, the patient that's on osimertinib for 40 years needed no osimertinib at all, right, because they're going to be recurrence-free. It's the patient that's on it for several years, gets resistant, that really benefited. We were able to prevent that up front. Curious how you, A, handle testing, and B, duration. It's a very difficult discussion.
Yeah, so absolutely. I think this trial really, it's truly a testament to the importance of now even more testing, for sure, even in the presence of positive tissue for an EGFR, even just with a PCR, very simple, just a few days in terms of turnaround time. And now that we will have most likely this option for our patients. I think I have a lot of discussions with my patients in this setting. I have to say that I tend to take really to heart, and it's probably a matter of character in terms of the conversation with our patients of what matters to them. Some patients will have severe anxiety and distress from thinking of having to give up to that 80 milligram Q daily osimertinib tablet, especially those who are very functional with a wonderful performance status, absolutely active. They're not really missing out, right, in their routine by taking that osimertinib. So that's a population of patients where, especially looking at the survival curves from the ADAURA after 3 years, where I would consider continuing definitely until progression. You're absolutely right. We don't really know what's the number needed to treat here, right? To understand who are the patients that really would need the osimertinib forever, and those are the patients that can really benefit from a break and then restarting. And I really appreciate the short-term follow-up with a scan for 6 weeks to avoid really a persistence of resistance that cannot be manageable, afterwards.
Absolutely. And I think for Jonathan, one thing I'm curious about is the mechanism of these drugs informs duration, right? And so immunotherapy, the immune checkpoint blockade, it's actually a prodrug. The actual drug is the patient's own antigen-specific T cells optimally. Meanwhile, with these small molecule inhibitors, we're putting cancer cells to sleep. We may or may not be eradicating them. Some of the initial data for small molecules, the PAT-CR rates are lower than what we'd expect, but the radiographic imaging is quite impressive, and you wonder how much that's hibernating tumor. And so as someone who has to go in and actually remove these lesions, do you think there's some substantive differences based on the mechanism of the treatment we give up front in terms of the outcome?
Yeah, so I think this is fantastic for patients. First of all, I think this is really important study. It will question the utility of surgery in this space, but maybe only because it's given indefinitely afterwards. Part of the reason I think Pacific had such a significant effect, and this study does, is because chemo-RT is an imperfect form of local regional therapy. So there's a lot of residual disease to salvage. I think in general, for resectable disease, surgery offers better local regional control. That's been shown many times. And so the question emerges whether you need such long duration of treatment, and the NeoAdora study will probably have results at some point this year, and it'll be interesting to see what the rates of PAT-CR are and how that all fits with the surgical resection. But in my mind, I would really like to see more of these treatments moving towards a true cure type regimen where you're not assigning the patient to lifelong treatment. And while this is a major step forward, it's not necessarily addressing all of the needs that these patients have, which is to sort of define a treatment that will bring an end to therapy, but in a definitive kind of way.
Absolutely. There are 3 questions from the audience. I will just quickly answer to one of them because the other 2 will be probably tackled by Dr. Spicer. So the Pacific paradigm is for all non-small cell lung cancer with both histologies, as we discussed in that forest plot. And then for the next 2, I'm sure that we will just tackle these questions in the discussion. So we can go on, and I'll just pass it to Jonathan to discuss now the earlier stage.
Sure, thank you so much. This has been really good discussion, and it's kind of cool to go from metastatic to increasingly local regional disease. It's really the way these medicines have been explored, and this is a very exciting time. Now, when we think of how to administer care to the resectable patient, I think it's true for the unresectable locally advanced patient, is trying to determine the sequence of treatments. We know a fair proportion of patients will be cured with surgery alone, and for the time being anyways, our TNM staging gives us a certain sense of the probability of micrometastasis. We know that a high proportion of stage 3 patients have micrometastatic disease. A reasonable proportion of stage 2 patients do, but we don't have the assay to tell specifically who does and who doesn't. So we're sort of in a mode now as things move forward when we have stage 2 or 3 disease to presumptively treat micrometastasis first with systemic therapy and then to try and provide local consolidation with surgery thereafter. So this is what's happening. And then the question is, with the systemic therapy application, are you getting true control in the distant sites and getting this sort of notion of regression to the primary, which seems to be the case from the 816 data that you were referring to, Dr. Cascon, so that actually Patrick presented a year and a half ago at ELCC, where we saw a 50% reduction in the metastatic progression. Not so much of an effect on the local regional basin, though. That was still about 19% local regional progression. So this is the paradigm that we're in. The perioperative regimens are, this is looking at TNM 8th edition. And these are the patients in whom these neoadjuvant or perioperative regimens are eligible. You can see this box here, which is sort of provocatively drawn across the 3As and 3Bs, where some would be assigned to unresectable regimens and others would be assigned to resectable regimens. And this is a big area of unmet need where we're not really clear how these patients are defined. Why would you send one here and the other one there? This is an area where we need more data, more real-world data. And this was a consensus statement we put together for the AATS just recently. Nodal staging, we've talked about in the unresectable setting. It's just as important, if not more important, in the resectable space to get adequate nodal staging, and there are clear guidelines on this, so you should rely on your pulmonologists and surgeons to effect that proper staging, and not hesitate to redo it if it has been done improperly. This slide really just speaks to all the evolutions that have taken place. I used to be jealous about the metastatic timelines where you had all these different approvals. Now it's, in the space of a few years, it's the same in the early stage and really growing fast. But there's also been a lot of improvements in the context of thoracic surgery. We have more and more minimally invasive resections. Robotic now is the most common way lungs are resected in the US. We have this enhanced recovery after surgery, which actually often involves prehabilitation. So, again, a reason why to involve your surgeon early is these teams might have efforts in place of getting that patient improve their fitness, smoking cessation, so that they come to the OR in the best possible condition. We're getting better at sublobar resections. It doesn't really necessarily, for the time being, apply to the locally advanced setting, but it might one day. And now mixing all that up with the systemic therapies, it's just making for a really exciting time. How do we select patients? Well, as I said, staging is critical. At a minimum, CT, PET, invasive staging of some kind, preferably EBUS, brain MRI. So I think that's definitely true in the US. We often have trouble accessing brain imaging in Canada, so we'll satisfy ourselves with the CT. But when we have ALK or EGFR patients, or say stage 3B, then those are the patients we might be more choosy on getting an MRI. The physiological evaluation is absolutely critical. You can have a very resectable, anatomically resectable disease in a patient who's totally inoperable. And I think, again, this is another reason why you sort of need the eyeball test from the surgeon and a proper in-person or at least virtual evaluation to determine whether basic physiological evaluation is sufficient or if more advanced stuff needs to be done, like VQ scans, VO2 max assessments, which are all things that might be add-ons that help you determine the operability of the patient. And we've talked a lot about biomarker testing now with Alina and Adora and Laura, all these names coming out. This is the bare minimum, is the PD-L1, ALK, and EGFR, but I think really moving towards panel-based testing, because so many of the other alterations that you can find might be informative about the utility of immunotherapy. This is a complex slide. There's a lot to consider about the sequencing. We have a lot of supportive evidence in the preclinical saying about the importance of giving immunotherapy prior to the removal of the drug, sort of what Dr. Patel was talking about with regards to sort of that immunization effect. And I think the more you have a high suspicion of micrometastatic disease, i.e. stage 3 disease, you really do need to go to that approach. It seems to me a little bit unreasonable to offer upfront surgery to stage 3 except for very specific circumstances. Folks will advocate for adjuvant because there's no surgical delays, which I think isn't a problem if you're actually going to be a patient who's going to have early metastasis. But if you're a stage 2 patient who might be cured for surgery, then it's a very reasonable thing to do, and to then determine the adjuvant plan based on the pathology. And then the sandwich, which is the perioperative, which is the whole Cadillac kind of approach to the care of the patient, really allows multiple assessments throughout the course of treatment. You have a baseline assessment for the neoadjuvant. opportunity for eradication of micrometastatic disease. Then you have the information from the resection specimen and the ability to tailor the adjuvant course accordingly. So I think that's clearly where the whole field is moving. There's a lot happening. This is what we've seen so far in terms of results is truly the tip of the iceberg. There are many other studies from the first generation of studies, BR31, Anvil, Alchemist, Mermaid, a sort of whole portfolio of adjuvant studies which will have results not in the not too distant future. Empower 030, which we're expecting results on as well as a perioperative study. And then there's literally dozens of other studies that are still in that beneath the waterline that will be coming up in the coming years. So stay tuned. It's an exciting time. And it's now, used to be that there was no data about neoadjuvant or perioperative approaches. Now there's an abundance of it, and parsing through it is becoming increasingly difficult. So I'm going to try and highlight some of the main points going through this cross-trial comparison. So on the pathological response front, there are some numerical differences there, but they're all really in the same ballpark. We're not seeing a big incremental gain in terms of PCR between the 3-cycle regimen of 816 and any of the perioperatives, which were all 4-cycle regimens, when the patients could get to 4 cycles. There's differences between the Checkmate studies, which were based on a different type of pathological assessment than Keynote 671 and AGN. To what extent that's relevant in PCR, it probably isn't, but it might be to some extent for the MPR assessment. We can maybe talk a bit about that at the end. This is interesting, data presented by Dr. Watt at ELCC, showing the differences in the resected population. So I'll draw your attention to the red boxes. Usually when we report these trials, we report on the intent to treat population, and that's where you'll see anything from 17 to 26% PCR rate. But that's omitting all of the patients who didn't make it to surgery. When we just look at the resected patients, it's actually interesting to see that the PCR rate is in the basically 1/3 of patients. And that's irrespective of whether the patient got 4 cycles or fewer than 4 cycles. So I think in general, 3 is sufficient. 4, you can do it, but it might not be making a big difference on the path response front. And you can expect PCR in about 1/3 of these patients, which is pretty impressive. The EFS data. So I think people like to compare between adjuvant and the neo or perioperative regimens. You must remember that the adjuvant studies have omitted all the R1 or R2 resections. They've omitted all the patients who are unfit for chemo or have had complications from surgery or have died after surgery. So you've omitted a huge cohort. So it's very hard to compare DFS to EFS. They really are very different patient populations, whereas the neoadjuvant and perioperative have randomized at the first diagnosis. But what's clear when you look across the board from neoadjuvant to perioperative, we've hit a plateau. Bringing PD-1 or PD-L1 in these stages really has hit a plateau of EFS at 2 years in the 65% range. So we can do better, and that's exciting because there's more studies to do. This is the OS landmarks across the different studies. Cross-trial comparison always tricky here. The proportions and extents of disease are always hard to compare, but again, clearly showing benefits here. The statistically positive one from Keynote 671, the clinically important one from Checkmate 816, and we'll have the 4-year update tomorrow. And on the adjuvant front, really the only positive data we have is in the PD-L1 greater than 50% patients from the Empower 010 trial. So this is a bit of a busy slide, but speaking to sort of the resectability criteria, when I assess a patient in clinic, I want to know what they want. Do they want surgery to be part of their treatment algorithm? What is their risk tolerance? Do they have the tolerance to risk that is aligned with what their surgical profile would look like? What is your surgeon's experience with these types of treatments? Are they in their first handful of cases? Do they have a team of surgeons who can take these on and do so in a safe way? And what is that surgeon's risk tolerance? Because that'll determine which patients they'll be prepared to offer this to and which ones they won't. And that's quite variable as well. We talked about the baseline physiology assessments. Those are pretty robust and well documented in the thoracic literature, so we apply those as needed. And then in terms of the R0 resection, you have to remember all these trials had the implication that patients could be resected at baseline. So you want your surgeons to be able to say, yes, before you start neoadjuvant, I can get an R0 in this patient. Those are the ones who are most likely to benefit. And in all of the trials we've looked at, the patients who get an R0 are the ones who have a favorable hazard ratio. When you have R plus resection, there isn't much of an advantage to either a neoadjuvant or a perioperative regimen. So this is really what we're aiming for. Looking somewhat aspirationally, perhaps there are some categories of patients in whom the likelihood of response is so high that you might push the envelope and you might try to convert a patient from, but this is really more exploratory and really wasn't the basis upon which the trials were designed. And at the end, you really have to compare what is the risk-benefit profile to the other alternatives, which Dr. Kescon really explained quite nicely. People often ask us, is it more technically challenging to operate on patients who've received immunotherapy? These are nice data, again, from the NeoStar trial and the Cornell group, who've commented on the extent of hilar fibrosis in patients who have or have not received ICI. Certainly, from a complication standpoint, there's no difference. It is true that patients who have really good responses or have had protracted courses of IO or really any systemic therapy for that matter are a little bit harder to operate on, and you need to be prepared to use maybe some maneuvers that we don't use in the usual settings, such as PA control, PA plasties, and bronchoplasties, which also speaks to the need to have surgeons who are, I think, thoracic trained and capable of doing those things on a routine basis. The MD Anderson group actually did a really nice job of characterizing what were the features that led to more complex operations. And what it really boiled down to is the patients with clinical node 1, N1 disease. N2, we can resect N2. It's not really that technically difficult for the most part. N1 is problematic because the N1 nodes live between the bronchus and the pulmonary artery. And when you have a big N1 that responds really well, the plane that is usually easy to dissect between the bronchus and the PA sometimes is obliterated. And that's when you find yourself with seeing the inside of the PA in a bloodbath. So you need to be prepared for that. And those can be much more challenging. That's when we get proximal control and we might be doing more PA plasties. And so surgeons need to be aware of these issues. So this is all stuff that Dr. Donington, actually, we did a peer review together, and she put a lot of this together. So when she's doing, and I do this too, post-induction planning, you want to really discuss whether you're with the patient, whether you're going to be doing this MIS and open. We have nice quality of life data now showing that there's really no difference in terms of the return to baseline quality of life, whether you do it open or MIS. So don't come down on your surgeon and say, wow, you made a big incision. They did the safe thing in their hands, and the patient actually recovers on the medium term at the same rate. It's a very modest difference on the short term. Open operations are safe and good, and it's the oncologic result that really matters. We like to work with a strong assistant in these settings. Often these are 2 attending cases when they're looking a little bit more difficult. And like I said, don't give your surgeon a hard time if they've had to convert for some challenges. This is a great study that actually Tina and the team at MD Anderson produced on the notion of nodal flare. And the context in which I would refer to this is in terms of post-induction planning. A lot of people are ordering post-induction PET scans. We've stopped doing that, not because we don't think that there's useful information to be gathered there, but for us it's a resource issue, but I also think it often generates some confusing information. You may see some nodes that light up that actually are just flare, and so you kind of get into the spiral of re-invasive staging, and it may not be pertinent. So we really do repeat invasive staging in patients that have clear contralateral disease or something that we want to check to exclude them. I'm wondering what your practice is at MD Anderson in terms of the restaging.
Yes, I think that since this data and really the real world experience, many actually phase 3 trials have removed the post neoadjuvant PET scan PET-CT that was initially mandated. I think, correct me if I'm wrong, only the 816 at this moment in time is the trial that will have a PET post-neoadjuvant chemoimmunotherapy. Many trials have been amended based on this result, absolutely to your point, to minimize that additional invasive procedures, new biopsies, new invasive medial sentinel staging to be done to ensure resectability with curative surgery still appropriate. This is not a trivial percentage, right? The radiographic appearance, right, of nodal involvement with potential concern for progression, 16% of patients on the New Star randomized trial. And I cannot tell you enough the sadness, right, at tumor board in seeing these patients be in disposition to standard of care because they have failed New Star to a point where, well, let's start biopsying all these lymph nodes because this doesn't seem right. And then sarcoid-like reaction in these lymph nodes that was really a de novo phenomenon, really an immune-based flare with sarcomatoid reaction that was not present in the lymph nodes at baseline. So I think really definitely a step forward to minimize more testing and really spare our patients and our teams from additional procedures that are not needed.
Yeah. We commit to it. So if the patient was resectable, we proceed to surgery. So last few slides on some of the controversial subjects. So for stage 2, I really advocate neoadjuvant. We did a meta-analysis showing that the hazard ratio is quite significantly in favor of the addition of immunotherapy, hazard ratio of 0.71. We already knew that in stage 3 it was going to be significantly beneficial, but this just further confirms that. And on the PD-L1 testing front, we had positivity across. There is a gradient of magnitude of effect, but clearly positive in the PD-L1 negatives. So Dr. Haymack and Dr. Cascone will be presenting subsets of the N2 patients tomorrow, which I think should be interesting discussions and informative about the utility of perioperative strategy, and then I'll be giving the 4-year update for Checkmate 816. This is a patient of mine, 61-year-old patient with a left upper lobe mass, adenocarcinoma on biopsy, PD-L1 0, G12C mutation, stage T3N1, good lung function. We offered this patient chemoimmunotherapy. They weren't able to get to that 3rd dose because of some COVID, but you can see there's radiographic response and proceeded to resection. And you can see despite the radiographic response, there isn't a great response to chemoimmunotherapy. The patient has a percent RVT of 61%, and it's still a T2B-N1 after resection. So how do you guys handle the chemotherapy if they've had an insufficient dose preoperatively? How do you assess
Yeah,
that?
I can start off with that. I have to say this is always a very, not point of contention, but definitely of discussion. If they had received 3 cycles, so that's the bulk of the platinum-based chemotherapy, and we know from historical meta-analysis from the LACE and from the neoadjuvant group that really the 5-year overall survival improvement, the net improvement is 5% with either pre or post 4 cycles of chemotherapy. So in that case, if I've given 3 cycles, I wouldn't give an extra cycle. If I've given 2 cycles and there has been a toxicity and an issue, right, based on which the patient has not been able to receive more therapy and the patient has recovered, I could consider that as a completion from 2 to 4 cycles. But I think the real question here, do we continue the immunotherapy or do we disposition the patient to another type of intensification as part of the approach?
Absolutely. And I think we actually have a couple questions from the audience on this. And so maybe rapid fire in the time we have left and kind of related to that question. We have a question from the audience. Maybe I'll alternate between y'all if that's okay. The first is, can you please answer what you do with a patient with substantial residual disease after neoadjuvant chemo IO? Are you comfortable recommending radiation plus or minus consolidative IO? If so, what immunotherapy have you used? Are you using durvalumab, kind of merging Pacific, right, with one of the neoadjuvant approaches? How would you handle that scenario?
Well, I think that the patient has a robust residual disease after a chemoimmunotherapy neoadjuvant approach. I take in consideration several factors. I take in consideration if this is a stage 3 disease, specifically, in the context of multi-station stage 3 disease, and hopefully you'll see why in the upcoming presentations. And I have to say, the PD-L1 status is something that, at least here in the United States, we don't select based upon the choice or not of giving a neoadjuvant chemoimmunotherapy. If I have the opportunity to enroll this patient on an intensification strategy on a trial, that's what I would do. And also it's a matter of, it's only residual pathological disease, but there are no other patterns of failure, because that's when, of course, radiation therapy would come in play. So again, a multidisciplinary discussion with a lot of factors to keep in mind.
Great points. And Jonathan, we talked a lot about stage 3 and stage 2. What about a stage 1 patient? What does that discussion look like in your clinic?
Well, as much as possible, I like to offer them all of the options. Even though surgery is still sort of the standard of care for stage 1, it's important for them to know that they have options with SBRT, and we like to do these meetings in the multi-D clinic. We know there's high-risk stage 1. We need more trials in that space. We encourage our surgeons to do proper nodal investigation, proper staging, so we don't miss this incidental stage 2s and 3s. But really, it's upfront surgery for the majority of those patients for the time being.
Absolutely. And so let's say we're giving this talk in 5 years. We got good feedback from the audience. We're invited back. What do you think the biomarker assessment for these patients are? Is it a combination of PathCR? Is there MRD? Is it going to be tumor-informed? What do you think that discussion is going to look like?
I think absolutely it's not going to be an N01. It's going to be really a composite type of biomarkers that will be patient-based, tumor-based, so tumor-informed, with the PD-L1, with the molecular profiling, the genetic makeup, the clearance with the ctDNA longitudinally, as well as a number of other factors, specifically not only the stage of 3 disease, but how all those factors work together with the genetic makeup. I think we're going to be really in personalized type of chemoimmunotherapy approach, not too far from now.
Absolutely. And so with that, I want to thank my faculty. This is as good a discussion from the experts as you can get on the podium in McCormick as well. Please visit us at peerview.com/2024 non-small NSCLC. Please complete and submit your post-test and evaluation for credit. You can download these slides and practice aids. Watch the replay of this event in the next 24 hours with the online activity coming in coming weeks. And so thank you for joining us for this activity from PeerView Live. And thanks for LUNGevity, AZ, and BMS for sponsoring this work. That really just shows that we're able to take these very promising therapies, bring them to earlier stage disease to maximize the benefit for our patients. And we've seen this time and again. The mortality from lung cancer has driven the overall reduction in cancer mortality over the past several years. And it's driven by immunotherapy approaches, driven by targeted therapy approaches, and what you've heard from my colleagues. And so thank you, and I hope folks have a wonderful meeting and rest of their night.
Thank you.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, LUNGevity Foundation. This activity is supported by independent educational grants from AstraZeneca and Bristol Myers Squibb.